Good evening, ladies. Okay, let's see if we can get through the last three chapters for Module 9. I am going to start with drugs used to treat diabetes mellitus. Please review the objectives. So, diabetes mellitus is a group of diseases characterized by hyperglycemia and abnormalities in fat, carbohydrate, and protein metabolism. Diabetes is characterized by abnormalities in fat, carbohydrates, and metabolism. Incidence: it is prevalent in the general population, is estimated at 9.4% or 23.1 million people. Higher incidence occurring among school-age obese children who have poor diets and do not exercise. And it is classified into four subclasses. Diabetes leads to microvascular, and neuropathic complications. Incidence with diabetes is higher in African Americans, Hispanics, American Indians, Native Alaskans, and women. And if you follow me with the slides, there's a question in regard to the percentage. And then we're going to move into type 1 diabetes. Because remember, there are four subclasses. So we're going to talk about type 1 diabetes. It's caused by an autoimmune destruction of the beta cells in the pancreas. No insulin secretion. There's no insulin secretion from the pancreas. So this is type 1. It's generally early age of onset. Symptoms is polydipsia, polyphagia, and polyuria. Weight loss. The pancreas can no longer secrete insulin. It requires estrogenous insulin and is formerly known as insulin-dependent diabetes. Type 1 diabetes usually occurs among school-age children who may blank out or pass out at school, and it requires lifelong exogenous insulin, meaning that required to actually take some form of insulin, okay? Type 2 diabetes represents 90 to 95% of the diabetic population. It's a metabolic syndrome, and it is common among these patients. Please refer to box 35.1. So, again, type 2 diabetes makes up 90 to 95% of the patients with diabetes. It is characterized by a decrease in beta cell activity or insulin deficiency. So, they have an insulin deficiency. And insulin resistance, increased liver production of glucose. Many patients have metabolic syndrome, slower symptom onset. This has a slower symptom onset, and older age at an onset. So it's slower, and it's usually with people who are older, okay? They require supplemental insulin or oral anti-diabetic drug is usually prescribed for type 2. So basically their pancreas does make some insulin, but sometimes it's not enough. So please refer to table 35.1. That was table 35.1, yeah. So the classification of diabetes. Other specific types is endocrinopathies, drug or chemical-induced infection, genetic syndromes. Also, there's gestational diabetes mellitus. It's an abnormal glucose tolerance during pregnancy. So gestational diabetes, or GDM, is abnormal glucose tolerance during pregnancy, and this may occur in 7% of pregnancies. It must be reclassified if it is persistent 6 weeks post-delivery. So if a mom has a baby and she's still presenting with symptoms 6 weeks after the baby, they have to reclassify it because she might be a type 2 diabetes. Um, Other types of diabetes are usually temporary and may be treated with insulin or oral hypoglycemic agents. So either with insulin or some kind of diabetic pill. Treatment for gestational diabetes is strictly regulated by the obstetrician for medication, activity, and diet management. So let's talk about glucose levels. Fasting plasma glucose. Doctors, these are blood tests that the doctors may check for possible diabetes. And a normal fasting glucose, they like to see less than 100 milligrams per deciliter in the blood. Okay. If it's greater than or equal to 100 milligrams per deciliter, but less than 126, they call this impaired fasting glucose. If they do what they call a 2-hour fasting postprandial glucose, they like to see that if it's at like 140 or greater but less than 199, they call this an impaired glucose tolerance. Okay, so patients with impaired glucose tolerance are often euglycemic and develop hyperglycemia when challenged with an oral glucose tolerance test. Prediabetes is now recognized as the intermediate stage between normal glucose homeostasis and diabetes. So a patient may have some pre-existing symptoms where they are classified as pre-diabetic. So complications of diabetes. So I mentioned microvascular. So they can have microvascular complications, and this is where there's a destruction of the capillaries. Okay, so in the eyes, this can cause blindness or retinopathy, which is damage to the retina. In the kidneys, this can cause neuropathy, which is a general term for kidney disease, and or renal failure. It can also, now we're talking microvascular, it can also involve the peripheral tissue, which causes neuropathies, which really is kidney diseases that cause damage to the kidneys or impair the kidney function. So now we're talking macrovascular. So now we're talking the bigger, like veins and arteries, okay? So atherosclerosis of the middle to the large arteries, such as the heart and brain. And this can result in stroke, MI, or peripheral vascular disease. So again, if microvascular system is affected, it's a long-term. These can be long-term complications that affect small blood vessels. The most common microvascular complications are diabetic retinopathy, that's where it can affect the damage to the retina, and diabetic neuropathy and kidneys. So it can affect the eyes and the kidneys. Those are the two main areas that you will see with micro. With macular vascular, this is a disease of the large arteries and veins that can lead to stroke, heart attack, peripheral artery disease. They are caused by a buildup of plaque in the arteries, which can narrow or obstruct blood flow. These can also, both micro and macrovascular, can lead to comorbid diseases. So please see figure 35.1. Diabetic patients are also more susceptible to infection. Okay? So the goal of treatment is to prevent ketoacidosis and minimize the incidence and effects of hyperglycemia. The goals of dietary control is to prevent excessive postprandial hyperglycemia, prevent hypoglycemia, help the patient maintain a normal weight, and reduce elevated cholesterol and triglyceride levels. Diabetes mellitus is a lifelong disease that requires constant monitoring and evaluation. Dietary treatment of diabetes using medical nutrition therapy, or MNT, and exercise constitute the basis of management for most patients. So I am on slide 12, and we're going to talk now about drug therapy for diabetes. The primary goal of treatment of type 1 and type 2 diabetes is normalizing the blood glucose or blood sugar levels. Patients should check blood glucose levels before each meal and at bedtime. The American Diabetic Association recommends patients with pre-diabetes be treated to prevent delayed onset of type 2 diabetes. Patients should be encouraged to limit the amount of time they spend being sedentary or non-mobile. They need to be active, so they should limit their sedentary time by breaking up extended amount of time, greater than 90 minutes spent sitting. So they should, if they're sitting for more than 90 minutes, they need to get up and move around, okay? Drug therapies continue. I'm on slide number 13. Metformin is a common oral form of diabetic medication that you will see, and probably the most common. Please refer to figure 35.2 and table 35.4. That's figure 35.2 and table 35.4. So initial anti-diabetic therapy for type 2 is highly dependent on the patient's success with lifestyle modifications and diet control. So when a patient has type 2 and the doctor is considering them taking an oral pill, the patient's compliance with their lifestyle modification, meaning some exercise and diet control, their medication regime will be based on their lifestyle modifications. Okay? So I am on slide 14. Now we're going to talk about nursing implications. So you're going in to do your physical assessment. So you want to ask a patient about their hyper and hypoglycemic episodes. What's going on if they have any illness or stress? Have they had any vascular changes? Are they having any neuropathy? Well, neuropathy, that's involves their feet. They may also have it in their fingertips. Most people have like a stinging or tingling sensation. Some say it's stabbing and burning, but that's what neuropathy is. It's very common with diabetics. And also their weight. Are we working on weight management, diet changes, exercise regime? Are they doing their follow-up laboratory studies? A1C is a lab test that doctors often prescribe to see how the patient is doing diabetic-wise over a span of time. So when they do a blood sugar poke, that tells them where their blood sugar levels are like right now. A1C looks at the blood sugar levels over a period of time to see how consistent they are. Again, their nutrition and their psychosocial, is doing psychosocial assessment. How are they mentally? Are their needs being met? Things like that. Are they compliant with their medications? And again, activity and exercise. Illness and stress may bring about both hypo and hyperglycemic episodes. So it is important to teach and educate the patient, to try to keep their stress minimized and be mindful of any illnesses they have, because they might contribute to hypo or hyperglycemic episodes. To detect vascular changes, check them, they'll make sure they're seeing most likely an ophthalmologist or some kind of eye doctor on a frequent basis. And with neuropathy, the burning, the stinging, the tingling, foot care for these patients is extremely important, because they need to be constantly checked for infection or any kind of breakdown, because they're having poor circulation because of the microvascular. If their microvascular system is involved, okay? So with your patient education, intensive therapy is comprehensive program of diabetes mellitus. A lot of the hospitals or the doctors may especially if a patient is newly diagnosed. Recommend that they go through some kind of comprehensive program to teach them about diabetes and the importance of being compliant with their medication and their diet and their exercise and their medications that they're taking. And to teach them how to self-monitor their glucose levels, how to actually do their glucose levels, their medical nutrition therapy, and again, exercise. And with type 1, 3 or more insulin injections per day may be required, or an insulin pump. Maintaining blood pressure control, maintaining normal blood lipids, so managing that cholesterol and triglycerol levels, maintaining a BMI less than 25 kilograms per M2, and recognizing symptoms, teaching them the signs and symptoms of hyper and hypoglycemia. Patients need constant, continual education. So you as the nurse, and that's your role as your patients come in, to continually educate and teach them so that they become informed on what to look for, what to watch for, and the importance of being compliant with all their health regime, the medications, the exercise, the diet, the meds. Also recommend smoking cessation. If they're a smoker, try to encourage them to get on board with some kind of cessation program, and be aware of psychological adjustments. And the American Diabetic Association has developed areas of diabetic education. So if you work in what we consider a specialty, diabetes would be a specialty clinic or office. So teaching is going to be huge, and educating your patients is going to be huge. So moving on to nutrition, I'm on slide 16. Diet used alone can be diet modification alone, or it can be in conjunction with medications. They have to learn how to do exchange lists. This is where nutrition management is huge. So they can learn how to exchange things in their diet to maintain their glucose, help them with because carbs is huge. Remember, carbohydrates and fats is part of that diet piece. Consistent carb diabetes plan. They may be on a 1,500 to 2,000 calorie diet. They may have to only take in 45 to 65% of their carbs, 10 to 35% of proteins, 20 to 35% of fats. Weight loss might be recommended for a high BMI. That's the body mass index. Diet needs change with growing children who are diabetics, and adolescents, and pregnant and lactating women, and older adults. Sick day plan. Okay, I'm on slide 17. Talks about activity and exercise. We want the patient to maintain a normal lifestyle, including exercise. Gradually increase the duration and frequency. Educate the patient. They should consult with their prescriber before initiating any kind of exercise program. They need to be diligent in monitoring their glucose level before, during, and after exercise. Encourage them to drink sufficient fluids. Get plenty of water. Exercise helps the cells use glucose and lower the glucose level. So exercise is huge if we can get them in a good, steady exercise regime. Stop exercising, and you want to educate your patients to stop exercising if they feel weak, dizzy, or sick. Okay? I am moving on to slide number 18. This is in regard to medication. And this is slide 18, I believe. Please inform and teach and educate your patients to not make changes to their medications without medical supervision. And also teach them to administer sub-Q injections, and how to mix their insulins if they have to, and dispose of them properly with needles. The good thing now is a lot of the insulin medications come in what we call pen form. So Hopefully they wouldn't have to mix their insulins. But if you're working in a diabetic clinic or dealing with a patient who require that, it's crucial to teach them the proper way for their insulin to be mixed and administered. Okay. Slide 19 is a question. And if you do the questions and you want to talk about them, we're gonna do a quick review over this tomorrow before the exam. So, and slide number 20 is a question. Slide 21. Moving on, we move into hypoglycemia, which is low blood sugar. Remember, hypo is low, hyper is high. So we're gonna talk about hypo or low blood sugar. It is caused by too much insulin or insufficient food intake. So if the patient is producing too much insulin in the pancreas and not taking in enough food, it's going to cause the blood sugar to go down. It can also be caused by vomiting and diarrhea and too much exercise. Okay. Symptoms you'll see is nervousness, tremors, and headache. Sometimes with a patient, you'll see apprehension. They may be sweating, cold, clammy, have clammy skin. They may be hungry. And this can lead to coma and death. And then I gave you all a handout for a quick reference. So hang on to those and use those in your clinicals if need be. On one side is hypo, on the other side is hyper. Treatment is administering food or liquids if the patient is able to swallow. If the patient is unable to swallow, we want to administer glucagon or IV fluids of 50% dextrose, and dextrose is sugar, so it gives them a little sugar. Glucose can come in the form of a gel that you can put under their tongue, or it can come in an injection. Okay, and you all got the handout for the hypo and hyper. So now we're gonna look at hyperglycemia. That's high blood sugar. It's caused by non-adherence or overeating. It can be caused by acute illness or infection. And the symptoms are often headache, nausea, vomiting, abdominal pain, dizziness, a rapid pulse, rapid shallow respirations. They have an acetone or sweet odor on their breath. And it may cause coma or death as well. Treatment for hyperglycemia, we want to administer IV fluids, administer insulin. You want to monitor their blood glucose. The patient may be checked for ketones because they may be spilling ketones in their urine, and their potassium levels. Okay? So I'm on slide 23. And this is complications associated with diabetes. Patients could have complications with cardiovascular disease, peripheral vascular disease, visual alterations, blindness. They can have renal disease, so it affects the kidneys. They can have frequent or more infections. They can have neuropathies, meaning concerns or issues with the nerves, and that's where neuropathy comes in, which is the most common one you probably will see with diabetes. Impotence, meaning the sex drive is low or non-existent, and they may also exhibit hypertension. Neuropathies, kidney disease that can, which is like kind of also like kidney disease. Related to the kidneys or impaired kidney function. Impotence is, again, the inability for a man to have an erection. Okay, so I'm now going to move on to slide 24. We're still going to talk about insulin. So the drugs in this class are with insulin. Insulins can be what we call rapid acting or acting really fast. They can be short acting, which means they only react for a small amount of time. It could be intermediate, meaning that it's not rapid, but it's not short, okay? Or it's not short, but it's not rapid either. It's intermediate, it's in the middle. Or they can have beyond what we call long-acting insulin. So the actions of insulin they are key regulators of metabolism. They're required for the entry of glucose into the skeletal muscle and fat, and they are needed for protein and lipid metabolism. They are used to control blood sugar in patients with diabetes. For more specific medications, or to see the medications in this class, please refer to table 35.2. That's table 35.2. Common and serious adverse effects with these meds is hyperglycemia, hypoglycemia, and allergic reactions. And please, and again, refer to the handout. I gave you a quick cheat sheet as far as that, which will probably come in handy if you're in the clinical setting and you're caring for a patient with diabetes when you're looking at signs and symptoms of hypo and hyperglycemia. Okay, so on the cheat sheet I gave you about the insulins. So your rapid acting insulins are gonna onset, or they're gonna become active within 10 minutes. They peak at 1 to 3 hours, and they last 3 to 5 hours. Okay, your short acting insulins are gonna start to work in about 30 minutes. The onset is about 30 minutes. They peak at 2.5 to 5 hours, and the duration is 5 to 10 hours. Your intermediate ones, those ones that insulin that kind of does that in between thing, will onset is 4 hours, or you might see it start to work in about 4 hours. So it peaks in 4 to 12, and it can last 16 to 24 hours. So with our long-acting insulins, they usually peak. The onset is about 1 hour. There really is no peak, but they last for about 24 hours. And for specific drugs, again, see table 35.5, and that's on page 567. So, when you have a patient with diabetes and you're doing patient education and teaching, it is very important to teach them how to store their insulin. So I'm on slide number 26, I believe, and it talks about storage of insulin. So tell the patients they are not to freeze their insulin. Their insulin is always to be stored in the refrigerator unopened, because once they open it, they can keep it at room temperature for 30 days. So do not freeze. They are to store it in the refrigerator until it's open. Insulin loses its substance or its potency at sustained higher room temperature. So they want to be mindful of not keeping it in too warm of a space. You want it at room temperature. Insulin bottles or cartridges may be kept at room temperature until gone. So once they open it, they can keep them at room temperature for 30 days. Tell the patients, do not shake the insulin. They are to roll their vials. They need to roll their vials or their pens gently in the palm of warm hands, and to just mix up the medication, okay? So they don't, not to shake, they are to roll. So nursing implications with insulin. Confirm acceptable glucose levels prior to administering the insulin. So if patients are instructed to take their blood sugars a certain amount of times a day, they need to make sure their glucose is in the range that has been established by the healthcare provider. Confirm anticipated activity level. You want to confirm that prescribed diet is being taken, or they're trying to monitor, stay in their exercise or their diet regime. Observe for signs of hypo and hyperglycemia. And teach your patient that they need to rotate their injection sites. So often when they're going through diabetic teaching, if they're learning this for the first time, they will be taught that there are certain areas sub-Q wise that they can rotate sites. So them rotating injection sites helps prevent atrophy or hyperatrophy of tissue, meaning it might get hard in those areas. So it's important that they rotate the sub-Q injection sites, okay, to try to avoid atrophy or hyperatrophy of the tissues. Slide 26, or is that 28? The numbers are so small, y'all. Oh, 28 is a question, and you can bring those to my attention tomorrow if you would like. I'm going to move on to slide number 29. And then we're talking about oral anti-diabetic agents. So metformin or glucophage is probably the most common one you're going to see. So this particular medication decreases the hepatic glucose production by inhibiting glycogenesis and glycolysis. It reduces the absorption of glucose from the intestine, and it increases insulin sensitivity. You'll probably see this is most commonly seen or used with type 2 diabetics. And the common adverse effects you'll see is nausea, vomiting, anorexia, and abdominal cramps and flatulence or gas. There are numerous drug and alcohol interactions with this particular medication, so it is critical that you teach get a good history and assessment from your patient so that you can teach and educate about any possible drug or alcohol interactions. When metformin is used when diet and exercise alone are not effective. So if a patient is pre-diabetic and the doctor is trying to manage them by diet and exercise, if it's not effective, this is when you may see a patient go on metformin. And the benefits of metformin is that it will not cause hypoglycemia. It does not cause weight gain, and it affects triglycerides to a moderate degree. Okay? Okay, this is slide number 30. So, and this one is talking about serious adverse effects of taking oral anti-diabetic agent. So the patient may be tired. They may have respiratory distress. They might have hypotension. They might have lactic acidosis. Patients with reduced renal function, you may also see poor circulation. They may have excessive alcohol intake, are most susceptible to lactic acidosis. So IV radioplaque dyes can be induced temporarily with renal insufficiency. Metformin should be discontinued 24 to 48 hours before procedures and 2 to 3 days after the procedure until normal renal function has returned. Okay, so the action of these actions of hypoglycemic agents is they stimulate the release of insulin from beta cells of the pancreas. They are effective in patients with type 2 diabetes mellitus. Common adverse effects you will see with these are nausea, vomiting, anorexia, and abdominal cramps. Serious adverse effects is hypoglycemia, hepatotoxicity, and blood dyscrasias. And blood dyscrasias is just a general term for any disease or disorder of the blood, bone marrow, or lymph tissue. It can affect red blood cells, white blood cells, or platelets. Or they might see dermatologic reactions, which means any like skin rash or anything related to the skin. Patients allergic to sulfonamides may be allergic to sulfonylureas. Okay. So for more specific drugs in this category, please see table 35.7. Many drug interactions are possible. So carefully review the medications patients are taking concurrently or on a regular basis with this particular medication. Slide number 32 is a question. Slide number 33. So these are meglitine oral hypoglycemic agents. I'm sorry, y'all. These particular medications stimulate the release of insulin from beta cells of the pancreas. So they stimulate the pancreas to release insulin. They are effective in patients with type 2 diabetes. Common and serious adverse effects is hypoglycemia. So it can drop their blood sugar. Okay. Slide number 34. These are thiazolidinediene oral hypoglycemic agents. The actions of these increase sensitivity of muscle and fat tissue to insulin. They inhibit hepatic glycogenesis and decrease hepatic glucose input. So these are effective in patients with type 2 diabetes as well. Common adverse effects is nausea, vomiting, anorexia, and abdominal cramps. You can see a lot of the common adverse effects are the same for most of these. Serious adverse effects is hypoglycemia and hepatotoxicity. For specific drugs in this category, please see table 35.9. And please note that these drugs do not stimulate the release of insulin from the beta cells of the pancreas. Insulin must be present for these particular drugs to work, okay? In type 2 diabetes, there might be some insulin being excreted, but it may be just, and it's usually not enough, okay? So now I'm on slide 35. We're talking about alpha glucosidase inhibitor agents. These medications inhibit the pancreatic alpha amylase and GA alpha glucoside hydrolase enzymes used in digestion of sugars. They're effective in patients with type 2 diabetes. Common adverse effects is abdominal cramps, diarrhea, and flatulence, which is gas. And the serious adverse effects is hypoglycemia and hepatotoxicity. Acarbose will not cause hypoglycemia. That's a particular med or Precoce. And please refer to table 35.10 and review those. I'm on slide 36. And these are your sodium glucose contratransporter 2 inhibitors. And they block the secretion of SGLT2 protein, dropping glucose reabsorption from 90% to less than 10%. These medications are used for treatment of hyperglycemia in type 2 diabetics and used as adjuncts to exercise. Common and serious adverse effects is hypotension, increase in low density lipo protein cholesterol. So remember, you want your low density lipocholesterol levels to be low. So you remember, those are the lousy ones. So you want those to be low, but it increases those. So that causes problem with like good grief. I was trying fatty arterial sclerosis kind of stuff. Cholesterol. So hypoglycemia, these are still common and serious adverse effects. Hypoglycemia, glycosuria, GI, urinary tract infections, or urinary tract infections, increased urination, antihypertensive agents. Please refer to table 3511. Slide number 37. These are your incretin mimetic agents. They are used, and the actions of these, they increase serum insulin and reduce glucose concentrations. They delay gastric emptying and reduces appetite. They're used in combination with other hypoglycemic agents and metformin to reduce elevated fasting and postprandial hyperglycemia. Common adverse effects is nausea, vomiting, and diarrhea. Please refer to table 35.12 to review the drugs in this category. I'm on slide number 38. I believe 36. This is 38. Yeah, 38. Okay, so we were talking about incretin mimetic agents. So severe adverse effects of this drug class is hypoglycemia and pancreatitis. It is also associated with thyroid tumors in animals. It is administered sub-Q in the thigh, abdomen, or upper arm. Don't give after meals. It cannot be frozen. It may be kept at room temperature for 30 days, and then it needs to be discarded. So now I'm on slide 39. These are your dipeptidyl peptidase 4 inhibitors. And these meds prolong life of active GLP-1 and GIP, incretin hormones. They are used alone or in combination with other therapies to reduce elevated fasting and postprandial hyperglycemia and type 2 diabetes. Common adverse effects is nausea, abdominal pain, and diarrhea. And serious adverse effects is hypoglycemia, upper respiratory infection, and pancreatitis. The enzyme DPP4 quickly metabolizes GIP and GLP-1. Stiglepin and DPP4 inhibitor slows this effect. Drug interactions are of concern when using cistagliptin. Please refer to table 35.13. Okay, I am on slide number 40. These are your anti-hypoglycemic agents. So these are meds that's used to treat hypoglycemia, and it helps get the blood sugar up. So the most common one you will see is glucagon, and what it does is break down stored glycogen to glucose. It's the treatment for hypoglycemic reactions. Common and serious adverse effects is nausea and vomiting. These can be administered sub-Q, IM, or IV, and the patient should respond within 5 to 20 minutes. If not, 1 or 2 additional doses can be given. Glucagon is dependent on the presence of glycogen for action. In cases of starvation, adrenal insufficiency, or chronic hypoglycemia, it will not work. Glucagon also aids in converting amino acids to glucose, and it can be administered, again, sub-Q, IM, or IV. And that is it for chapter 35. Okay, so chapter 36 talks about drugs used to treat thyroid disease. I'm going to request that you look over the objectives. So, I'm going to jump right in on slide 3. So, thyroid functions. The hypothalamus secretes thyroid trypsin releasing hormone, or you hear referred to as TRH. It also secretes anti-pituitary. I apologize. The anterior pituitary secretes thyroid stimulating hormone TSH in response to TRH. Thyroid gland secretes T3 and T4 in response to TSH. T3 and T4 regulates general body metabolism, carbohydrate, protein, lipid metabolism, thermoregulation, cardiovascular function, growth and maturation, lactation, and reproduction. Thyroid function is regulated by the hypothalamus and the anterior pituitary gland. Synthesis of thyroid hormones depends on sufficient iodine intake through foods and water. Please refer to figures 36.1 and 36.2. Okay, slide number 4. One disorder of the thyroid is called hyperthyroidism. It's inadequate thyroid hormones. So you might see a disorder called mydexia. It occurs during adult life. And creatinism is born, a baby is born without a thyroid gland, or it functions really low. So they might have a hypoactive thyroid gland. Symptoms include slowed motion, speech or mental process, lethargy, decreased appetite, weight gain, decreased temperature, pulse and blood pressure, anemia and high cholesterol and constipation, or increased susceptibility to narcotics or anesthesia. And just so you know, mydexia is a term used to describe a skin condition and a severe form of hypothyroidism. Mydexia coma is a life-threatening medical emergency that can occur when hypothyroidism is left untreated. So, hyperthyroidism, another disorder of the thyroid, is an excessive production of thyroid hormone. So your thyroid is producing too much. And so diseases causing overproduction of thyroid hormone is Graves' disease, nodular goiter, thyroiditis, thyroid carcinoma or cancer of the thyroid, tumors of the pituitary gland. You might see an overdose of thyroid hormones. Thyroid toxicosis, also known as hyperthyroidism. Symptoms will be nervous, agitated, tremors, diarrhea, increased appetite, weight loss, xylophthalmos, a condition where the eyes bulge out of the sockets, increased temperature, pulse, and blood pressure. Slide number 6 is a question. Moving on to slide 7 is treatment of thyroid disease. The goal of therapy is to return to normal thyroid state. 2 classes of drugs as thyroid replacement hormones and anti-thyroid agents. Hyperthyroidism, 3 treatments are used. You will see subtotal. They can either end up with a subtotal thyroidectomy, where they take part of the thyroid. They may receive radioactive iodine or anti-thyroid medications. It may be 1 to 3 weeks after drug initiation before the drug effects are noticed. Okay? Let's see. Slide number 8. I think this is slide 8. I should have had this up on my power. Yep, slide number 8. Drug therapy for thyroid disease. 2 general classes of drugs. Those used to replace thyroid hormones in patients whose thyroid function is inadequate, which is hypothyroidism, or they're going to get an anti-thyroid agent used to suppress the synthesis of thyroid hormones. And those are for people who have overproduction, so hyperthyroidism, okay? Your nursing interventions for hypothyroidism: history of prior treatment of thyroid disorders. You want to know if the patient has any cardiac disease or adrenal insufficiency. Request a list of their medications being taken. What is their nutrition status? Are they on the low-calorie, high-fiber diet? Are they getting enough fluids? Warm, quiet environment. Lifelong thyroid replacement medications. They need the need for periodic lab studies. They may have to have lab work done periodically. Patient may experience depression. And not all systems may be affected. Nursing care, diagnosis, and treatment focus on affected systems. Okay? Encourage moderate exercise as tolerated. Focus on safety during ambulation. If there's muscle weakness or wasting or discomfort is present. Slide number 10 is a question. Slide number 11 talks about nursing interventions for hyper or overactive thyroid, okay? Again, you want to get the patient's history and request all medications they are taking. They may want to be in a cool, quiet environment, may have anxiety. They should be on a high-calorie diet, avoid caffeine, laxatives, and other GI stimulants. If surgery is planned for because of thyroid surgery is planned for hyperthyroidism, order a tracheostomy set at bedside, assess for bleeding, respiration distress, hoarseness, tinnitus, have an IV calcium available at the bedside. Slide 12 talks about thyroid replacement hormones. The action of these are to replace T3 and T4 hormones. They are used to return a patient to a normal thyroid state. Common and serious adverse effects is signs of hyperthyroidism, hyperglycemia, drug interactions. It's important to know what drugs your patient is taking because warfarin, digoxin, estrogens, and cholestyramines or cholesterol medications may interact with these particular meds. They need increased dosage of anticoagulants and decreased doses of digoxin. For specific drugs, see table 36.1. Levothyroxine is the most commonly used medication for this thyroid replacement. And patients taking oral hypoglycemic agents or insulin may require adjustments. Okay. Slide number 13 is a question. Slide 14, we're talking about anti-thyroid medications. The most common you probably is going to see is iodine 131. The action of this med it selectively destroys hyperactive thyroid tissue. Is used the treatment for hyperthyroidism for selected individuals. Common and serious adverse effects will be tenderness in the thyroid gland, hyperthyroidism, and hypothyroidism. Drug interaction with this medication is lithium. This is used primarily for certain patients who may not be candidates for more aggressive treatments. Iodine 131 is a radioactive isotope of iodine that is absorbed into the thyroid gland in high concentrations. It takes 3 to 6 months for full benefits to be seen with this med. It is extremely dangerous. So when you're dealing with it, you need to wear latex gloves and watch for personnel who have allergies and follow hospital policy for spills. It's a radioactive medication. Slide 15 is a question. Slide 16. Again, we're still talking about iodine 131. It is added to it is added to water and swallowed. Minimize your exposure. Wear latex gloves to administer or to dispose of the patient's excreta, or just wear gloves when you're dealing with it in general. If medication or if there's spills, follow agency policy and use containers for radioactive waste disposal. This has to be disposed in a radioactive container, okay? Other anti-thyroid medications you may see is PTU or Tapazole. The actions of these meds are to block the synthesis of T3 and T4. Uses is long-term treatment for hyperthyroidism and pre-surgical treatment. Common and serious adverse effects is purpuric, macular-papular rash, headache, nephrotoxicity, hepatotoxicity, bone marrow suppressing, lymph node enlargement. So this medication will not destroy the T3 and T4 already produced a few days to 3 weeks before symptoms improve. So it'll take anywhere from a few days to 3 weeks before the patient may see any kind of results. Drug interactions is your warfarin. Dosage may have to be increased. Digoxin doses may have to be decreased. And slide number 16 is a question. And that is it for chapter 36 on thyroid. Last but not least are your corticosteroids. Please, this is chapter 37. Please review your objectives. So, the functions of the adrenal glands is to secrete two types of corticosteroids. You have your mineral corticosteroids and your glucocorticosteroids. The adrenal glands are located at the top of each kidney. They also regulate sex hormones. Okay, mineral corticosteroids and glucocorticosteroids have different functions and adverse effects. Diseases associated with adrenal glands are Addison's disease, pheochromocytoma, and hyperpituitarism. So, slide number 4. So, your mineral corticosteroids maintain fluid and electrolyte balance and are used to treat adrenal insufficiency caused by hypopituitarism or Addison's disease. Your glucocorticoids regulate carbohydrates, proteins, and fat metabolism. Okay? Glucocorticosteroids have anti-inflammatory, anti-allergic, and immunosuppressant activity. Slide 5 is pre-medication assessment. So your pre-medication assessment is what you want to do prior to giving a medication. So if doctor is ordering labs, you want to check for any electrolyte imbalance. Record their INO and do their vital signs. You want to check for any signs of infection. Perform baseline assessment of the patient. Degree of alertness. How alert are they? Status of their hydration. Are they dehydrated? Previous treatment for ulcers, heartburn, or stomach pain. And test the stools for occult blood. Okay? So, lab values to check for electrolyte imbalance. You want to look at the potassium, calcium, sodium, and chloride. Signs of infection to look for in patients taking steroids is like general malaise or tiredness, sore throat, or they may have a little gray fever. Okay, slide number 8 talks about the nursing process implication. You want to monitor their glucose levels for elevation. Insulin may be required. Follow body's normal circadian rhythm. Corticosteroids, 2/3 of dose before 9 a.m., 1/3 of the dose late afternoon. Mineral corticoids maybe once daily in the evening. Monitor their daily weight. What's their INO? Additional doses may be needed if patient experiences stress, accidental injury, and encourage the patient to wear ID bracelet. Okay, slide 7. Patient education. Know when to educate them when to contact the healthcare provider. Perform appropriate skin care. Helping them cope with stress. Avoid infections. Ensure proper nutrition. Ensure regular exercise. Foster health maintenance. Maintain a healthy foster health maintenance and maintain a written record. So they might want to keep track and keep a record of what's going on. So back to these mineral corticoids. The action of these they affect fluid and electrolyte balance, causing sodium and water retention. So they're used treatment of adrenal insufficiency and in Addison's disease. The therapeutic outcomes, or the outcomes we'd like to see, is control of blood pressure, restoration of fluid and electrolyte balance. Adverse effects is sodium accumulation and potassium depletion. They may be used in combination with glucocorticoids. I think that's it. And then slide 9 is a question. And then I am moving on to slide 10, which is a question. So slide 11. Let's talk about the glucocorticoids. The actions of these are anti-inflammatory, anti-allergic, and immunosuppression. The uses are certain cancers, organ transplant, autoimmune diseases, allergies, and shock. Common and serious adverse effects you'll see with these are electrolyte imbalance, fluid accumulation because you're retaining sodium, susceptibility to infection, behavior changes, hyperglycemia, peptic ulcer formation, delayed wound healing, visual disturbances, and osteoporosis. For specific drugs in this category, please see Table 37.1. All corticosteroids and glucocorticoids and mineral corticoids share varying degrees of mineral corticoid and glucocorticoid effects. Alternate day therapy may be used to treat chronic conditions. Slide 12 is corticosteroid therapy drug interactions with diuretics. Corticosteroids may enhance the loss of potassium with warfarin. Corticosteroids may enhance or decrease anticoagulants effects of the warfarin. Oral hypoglycemic agents or insulin. Diabetics, pre-diabetic patients may be monitored for hyperglycemia. Okay, so with steroids, I'm on slide 13. They may do what they call a steroid taper. So what that means is they may taper if they're on steroids. This is not a med that they can just stop. It has to be tapered down. So abrupt discontinue of therapy may result in adrenal insufficiency. Symptoms may be fever, malaise, fatigue, weakness, dizziness, fainting, anorexia, nausea, hypotension, dyspnea, hypoglycemia, muscle and joint pain. Gradual withdrawal of steroid use prevents symptoms of adrenal insufficiency and allow the adrenal gland to start functioning again. And I just plugged in a little table on the slide to show you that's what a taper down may look like. They may take a certain milligrams for so many amount of days, and then they'll drop the dosage for a certain amount of days. So they slowly taper the patient down so that the patient does not go into adrenal insufficiency. Okay. Slide 16. I'm sorry, I'm on slide 16. And this is talking about using caution with therapy caution. So carefully monitor patients with if patient is a diabetic, if they have heart failure issues, hypertension, peptic ulcer disease, mental disturbances, or suspected infections. Corticosteroids may cause hyperglycemic in diabetics. They may cause symptoms of infection. They may induce hypertension. They may induce psychotic behavior changes in patients with a history of mental instability. So this is why it's important to get a good health history or assessment on your patient. Okay. Slide number 15 is a question. 16 is a question. 17 is a question. And that is it for corticosteroids and chapter 37. Thank you, ladies, and I hope that you all have a pleasant evening, and I will see you tomorrow.